Okay, electrical malfunction of the heart. Now this is going to be different. We've been looking at the mechanical functioning of the heart, you know, the vessels, the vascular system. We've talked about the electrical part of the heart, but now we're going to start talking about dysrhythmias. Bradycardia, tachycardia. What's tachycardia? Fast. Bradycardia? Slow. What do you think dysrhythmias? What does that mean, dys? We know that dys means difficult, right? Like dyspnea, that one. What do you think? I don't think I have it up here. Arrhythmia. What does arrhythmia mean? The A means without. So arrhythmia really means asystole, right? But they do use dysrhythmia and arrhythmias interchangeably sometimes. It's not correct, but they do use that sometimes. Now, sometimes you may have a patient that actually has a heart. They're getting an electrical stimulation. Like if when you put the AED on there, you know, the AED is looking for electrical activity. It's not looking for mechanical activity. How would you recognize mechanical activity in the heart? How could you assess that? Yes, you might hear the beats. If you didn't hear it, how else could you assess it? You might palpate it. You might feel it. That would tell you you've got mechanical contraction. Now, if you have if the electrical part of the heart's working, but none of the rest is, would you be able to feel a pulse? Yeah, it'd be like you turn the switch on, but the light bulb's out. Yeah. So, yeah, it's getting electricity to it, but because the mechanics are not working, you won't get a pulse, you won't get a contraction. So sometimes you may get a rhythm. If you put up, if I put the heart monitor on a patient, or if you hooked up the AED may go, oh, I recognize a rhythm here. Yeah, we've got electrical activity, but we're not getting any beating of the heart. We call that PEA, pulseless electrical activity, meaning we've got good electrical activity, but the bulb's burned out. The muscle's not working, so it doesn't produce a pulse. So that's why it's important before you put an AED on a patient that you check the pulse, because if they don't have a pulse, they're dead. Yeah. We don't want the AED to shock somebody that's not really dead. So we don't ever put it on them unless we know they don't have a pulse. But anyway, if the AED picks up electrical activity, right, and it may say no shock advised. So we don't shock PEA anyway, huh? Okay, I just said it. Is that what you're going to say? That's okay. If the mechanical part's not working, they're dead. Yeah. Johnny, do you have a question?
Yeah, I'm just trying to clear this up. So PEA, like the muscles aren't working, but electrical activities work.
Yes.
Okay. Just making sure.
Yep.
The heart died.
The heart, yeah, the muscle itself's not working. It's just like the light bulb's out. It doesn't contract. The electrical activity's going to it. You're flipping it on. It's getting power, but it's not able to contract. The muscles are dead. That's called PEA, pulseless electrical activity.
Does that mean everything else is supposed to follow the heart not working?
Try me one more time.
The mechanism, if the mechanical part of the heart's not working, then pretty much you just see everything else start following behind.
Well, you know, a patient can have PEA for a certain amount of time before they're like dead. Because, remember, what was the one feature of the heart that's unusual? Automaticity. Yeah, so as long as it's still got some oxygen in there somewhere, it may continue to pulse. You know, it may get electrical activity for several minutes after the heart's not actually working, until it has no more oxygen, then it goes, can't do it anymore. Okay, when we're looking at the mechanical malfunctions of the heart, we're talking about what's wrong with the heart muscle. You know, what's wrong with inside the anatomy of the heart. Angina pectoris, what did we say angina is? We get chest pain that results in angina because of what? Increasing demand on the heart. and the vessels are not wide enough to provide that. So you can't pump enough oxygenated blood through this little space because it's too small. Acute MI, what's the mechanical malfunction there? Heart attack, and it's because of why? The heart attack, the muscle can't contract, either because it's got dead tissue or it has a blockage, so there's a muscular issue there that's causing the problem. Congestive heart failure, that's going to be like the muscle's just not strong enough to get the job done, and it causes fluid to back up here, there, and yonder. Okay. Already talked about angina, insufficient blood flow to the heart because the vessels are constricted. But there is blood getting through there. It's different than a clot. With a clot, it's going to move to the smallest point where it can't move anymore, and it will then block the blood flow completely. With angina, you still got blood flow through there. Typically due to narrowed arteries, secondary to coronary artery disease. It usually comes about when the patient's under stress, when they're working too hard for the heart to keep up. And then as soon as they rest and relax, it usually goes away. We talked about an infarction. Infarction means tissue death. What's the word for just insufficient oxygen in the tissue? Ischemia. That's right, ischemia. So infarction means death. You can see a picture of it here. This is where it's actually dead. So you can see that if a patient has a heart attack and they go in, they get a cardiac catheterization or something, they can't bring this tissue back. It's dead. So from that point on, that guy is always going to have dead tissue in the heart that's not going to contract. So his heart is never going to be up to speed completely. It's never going to be back the way it was because it's got dead tissue in there. They can restore blood flow to the live tissues around it, but this part's dead. Congestive heart failure. We talked about this the other day. Congestive heart failure leads to inadequate pumping of the heart. Heart failure can come about because of this dead tissue here. It's not working. The heart can't keep up with the demand. So we've got heart failure. Inadequate pumping of the heart. If the heart can't pump, and we're talking about usually the left ventricle, if the left ventricle is too weak, too much dead tissue to do its job, where are we going to see the results of that? Besides diminished cardiac output, but it's going to back up where? It's going to back up into the lungs. That's right. Fluid buildup in the lungs, and then as that does, it's going to back up into the right ventricle, which then will ultimately back up throughout the system. So you may see patients that have fluid in their lungs and they have pedal edema. So those patients have some serious congestive heart failure. And it can be caused by other things besides just tissue death in the heart. Hypertension can lead to that. Just that constant pounding on the vessels can lead to congestive heart failure. Obstructive pulmonary disease, what is that? We talked about the other day. Obstructive means what? Something is clogging it up. So what would be a pulmonary disease that something is clogged? Yeah, emphysema. Remember we were talking about that? Emphysema and bronchitis interferes with the blood flow through the vessels, interferes with getting oxygen to the tissues. Can all lead to congestive heart failure. Oftentimes, congestive heart failure is secondary to a heart attack because of that dead tissue, right? With CHF, you may have patients that call because they have an exacerbation of CHF, congestive heart failure, but it's not really a heart attack. But it could be they've had a heart attack which has made their congestive heart failure worse. So you usually have a lot of coexisting problems here. Already said that. Already said that. said, if they don't treat the problem with left ventricular issues, it's going to lead to right ventricular failure also. Sometimes they just can't do anything about it. Signs and symptoms of congestive heart failure. They're usually going to be tachycardic. They very commonly are cyanotic. You'll see evidence of poor perfusion, hypoxia, difficulty breathing. I would have difficulty breathing if I had all that crap in my lungs. 2. Diaphoresis, that's what? Sweating, that's right. Pulmonary edema, very, very, very common sign of CHF. They're usually going to be very anxious. We're going to call that altered mental status. Even though they're not crazy, but they may be confused, they may be combative, they may be anxious. All that due to hypoxia. Talked about that before. You may see some pedal edema, which is edema in the feet. Where else would we see edema if you had a patient that was very sick and was bedbound? Yeah, you might see it in the lower back, so you got to look for it there too. Another thing you may see are engorged pulsating neck veins. What do we call that? Jugular vein distension, that's right. When it's backing up, you know, if you see JVD, what's that going to tell you? Blood's backing up from what chamber? Usually going to be from the right side. It's going to back up into the system, that's right. Now, would you expect to see, would you be more alarmed by this if you saw it when the patient was sitting up or when the patient was laying down? That's right. If you see that pulsating, really thick, engorged neck veins when they're sitting up, that's going against gravity, which is work. If you see them, you know, enlarged when they're laying down, you know, that's not as concerning because gravity is going to level that out. So that's not that big a deal. If you see that, that's a late sign. These people are seriously ill if you see a JVD, particularly if they are pulsating. Signs and symptoms of CHF, these are all the things we've already said. Pale, cool skin, shortness of breath. Their blood pressure could be all over the board. It could be high, it could be low. Distended neck veins, cyanosis. Probably, you know, mild cyanosis. Some of these patients are chronically cyanotic. Mild to severe confusion. It's just going to be a lack of oxygen to the brain. Y'all ready? See, some of these slides are these things. So, which is a pertinent negative for a patient with chest pain? We talked about pertinent negative. I want to see if you can remember what it is. Come on, y'all. Somebody didn't know going on anyway. Okay, what is a pertinent negative? Something that you might have expected to see and it's not there. So if they've got chest pain, we don't care if they have hip pain, right? That doesn't have anything to do with chest pain, right? If you got hip pain, they're not related in most cases. Headache, they've got chest pain, those are not related. So neither one of those are going to be right. So you got to select between pulmonary edema and hypotension. If you see a patient who's having chest pain and you see that they don't, which is more important that you look for, if they're hypotensive or if they have pulmonary edema? Pulmonary edema actually is the answer here. If they're not hypotensive, they could be hypertensive. Remember I said with blood pressure it could be all over the board. So not being hypotensive doesn't really tell you anything. If they don't have pulmonary edema, that's good. That may mean they don't have CHF, which is good. Answer is pulmonary edema. All right, the cardiac arrest part, we're going to move through here a little bit quicker because we've been through this stuff. The chain of survival, you know, somebody has to recognize there's a problem. Somebody has to call 911. Somebody has to start CPR. When are you going to have a better outcome? If you start CPR immediately or if you wait until the EMS crew gets there? Immediately. So somebody needs to do that. You need them to be defibrillated as soon as possible. If you don't start defibrillation until 10 minutes out, the survival rate is like almost nil. So rapid defibrillation, effective and early advanced life support. So as soon as you recognize you've got cardiac arrest, if you're on a basic truck, an EMT truck, you need to make sure you call for ALS. And then after the patient has got a return of spontaneous circulation, we call that a ROSCO, then they have to have good post-cardiac care after they've been resuscitated. Okay, I got to start here. Y'all ready? The dysrhythmia that has electrical activity but no pulse is produced. See if y'all remember. Good, you can hold a thought for longer than 10 minutes. Excellent. Okay, early CPR, it increases the survival chances. I'm going through this stuff because, like I told you, National Registry has a lot of CPR questions on there. If y'all haven't been reading your CPR text, you've got to do it. Three-way CPR can be delivered earlier. Get trained CPR professionals, train lay people to do CPR, and then the dispatchers can instruct people how to do CPR, and they can do it quite effectively. Rapid defibrillation, as soon as the defibrillator arrives, sooner it arrives, the more likely you're going to have a better outcome. One of the questions is on your test. If you have a patient in cardiac arrest when you get there, and family members or bystanders are doing good CPR, you can see they've got a good rate, they've got good compressions, they're ventilating the patient. How are you going to manage using your AED? As soon as possible. If you get there and nobody's doing CPR, when are you going to use your AED? Yep, after 5 cycles or 2 minutes of CPR. There's a significant amount of oxygen that stays in the bloodstream. You've got to get it circulated so you can get more oxygen to the heart before you shock it. They find the outcome is much better if you've got some good oxygenated blood circulating. Rapid transfer, maybe. Yeah, don't wait on scene for ALS. If you've shocked them a couple of times, you're doing CPR, you need to roll right away. Don't hang around waiting on them to come. If they say, we're 10 minutes out and you're 10 minutes from the hospital, we're going to the hospital. So those are things you're going to have to weigh. And maybe ALS can help you make that decision if you need that. Integrated post-cardiac arrest care, make sure you continue to provide oxygen to them. Not hyperventilation. They don't require hyperventilation. Think about this. When you all are sitting up, you're digesting, you're thinking, you're working, then yeah, you require more oxygen. If you're laying there almost comatose, everything is shut down except your heart, your brain, your lungs, how much oxygen do you really need? So your requirement is much less. So don't over-ventilate your patients. You want to get a 12-lead EKG as soon as possible. That's going to be ALS. You want to try to treat any manageable causes of cardiac arrest. Those are things you're probably going to not know what they are, but as you move on up, if you go on through the program, there are many treatable causes of cardiac arrest that you may be able to manage. Make sure you take them to the appropriate destination. If you've got a patient in cardiac arrest, what's going to be the most appropriate destination? The closest hospital. Yes. Don't bypass Valley Hospital, what's it called, near, while you're running to East Alabama. If you've got a cardiac arrest patient. Closest hospital. One of the things that they're doing now, and I think I mentioned this earlier, they're inducing hypothermia. They're finding that the outcome is much better. The sooner they can chill the patient down, if they can do this in the field, and there are some services throughout the country that they're actually doing this in the field, and it works. They've had good outcomes with that.
How you do it in the field?
Well, in some areas they actually have chilled fluids that they have. They have blankets where they actually blow cold air through there. Any way they can start taking the body temperature down helps. not going on how to. Now, there is a difference in AEDs. There's a semi-automatic and there's a fully automatic. We carry SAEDs. We just say AED, but it's a semi-automatic because we have to actually press the button on that. For the fully automatic, all they do is they hook it up, it goes through all the steps, and it shocks itself. So we use the semi-automatic because we have to press the button. We have a couple of different types of AEDs. Currently, most of your AEDs are going to be biphasic. Back in the olden days when I started, we only had monophasic. With monophasic, the charge, the electrical current, only goes one way through the heart. With biphasic, it sends a shock from, it goes two directions. It sends a shock in one direction and then the other, so they're kind of crossing the heart. So it requires much less energy to get the same job done. So it's not as damaging for the heart. You really lower the amount of joules. That's the unit of energy that we use. So it lowers the joules. So most of them are going to be biphasic. They've pretty much taken the monophasics off the market, which is good for all of us. Okay, the AED, it's only going to shock shockable rhythms, which means it is programmed to only shock a couple of rhythms. In the field, with a regular manual defibrillator, there's only a few rhythms that we're going to shock. Others we won't. So you need to know what the shockable rhythms are. The first one is going to be ventricular fibrillation. That's going to be the most common rhythm that your patients in cardiac arrest will go into. It's going to be ventricular fibrillation. And it will remain in fibrillation for several minutes. So the chances of catching that in fibrillation is pretty good. So if you start CPR, you get your AED on, there's a real good chance you'll be able to shock that if you get it on there early. So ventricular fibrillation is the most common first rhythm, and it persists for several minutes, typically. Ventricular tachycardia. Let me go back. Ventricular fibrillation, that means the ventricles, right? Fibrillation means it's going like this. When the heart fibrillates, it's firing all over. We send that little, the electrical pulse goes through the heart, and it's supposed to go along pathways so that they contract all at once. In fibrillation, they're all firing, little pins, cells firing all over the heart, and it can't get together, it can't get organized to get a pulse. So as long as they all fire at the same time, they can get that pulse. If not, they're firing all over the place, and it actually looks like a bag of worms. If you go and search on the internet and you watch ventricular fibrillation of the heart, you'll see it. It's just quivering. It's a little bag of, blood-filled sac, and it's just wiggling all over like it's got a bag of worms. That's ventricular fibrillation. Ventricular tachycardia, all that is the heart's just beating very fast. The ventricles are firing very fast. I have it on here. I can't remember what the thing is. Anyway, I'll tell you more about that. Let's see what y'all can get here. Primary pacemaker of the heart is the y'all are good. Let's see, 100%. The SA node. Somebody's just trying to be difficult here. Let me go back here. What was I going to tell you about ventricular fibrillation? Okay, ventricular tachycardia, just in case I can't remember what I've got subsequent to this. Ventricular tachycardia is going to be the ventricles tacking along really fast, right? Can you think of a circumstance where you have tachycardia, ventricular tachycardia, but you don't feel a pulse? What do we call that? It's basically PEA, isn't it? Where it doesn't create a pulse, but you've got a rhythm. Well, with ventricular tachycardia, it can be with a pulse, where you can actually feel it tacking along, and the patient's conscious. We can also have ventricular tachycardia that's pulseless, meaning the patient's dead. So with ventricular tachycardia, and this is important, the reason I'm telling you this is if you hook up the AED will shock ventricular tachycardia. That's when it will shock. So if the patient has a pulse, and you've got the AED on there, they have a pulse, the AED says ventricular tachycardia, it's going to say shock them. And we don't want you to do that. So VTAC, we shorten that to VTAC, VFib, ventricular fibrillation, or ventricular tachycardia, VTAC. With ventricular tachycardia, you must know if it has a pulse or not. You can have a pulse with ventricular fibrillation. That would be nada. Never. No, not ever. Ventricular fibrillation will not produce a pulse. Ventricular tachycardia may produce a pulse. It may not. All right, we already did this. Okay, let's look at a few cardiac rhythms. This is what we call a normal sinus rhythm. Does something about sinus ring a bell besides in your nose? Ring a nose? Huh? Yeah, we talked about this, the SA node, the primary pacemaker of the heart, right? The SA node. If the SA node is working right, this is what you're going to see. The key to this being a sinus rhythm is going to be this little bump here, which we call a P wave, and this tight complex right here. That's a sinus rhythm. That means that that SA node, the primary pacemaker, is working normally. That's why we call it a normal sinus rhythm. Sometimes you may see that abbreviated NSR. That's a normal sinus rhythm. You're not going to have to be able to recognize this rhythm, but you do need to be familiar with the terminology. This is sinus tachycardia. The main way we know this is sinus is the same two reasons, right? We know it's fast, so that makes it tachycardia, right? Sinus, there's a little bitty bump right here, and this complex is tight. That tells us it's sinus. So see the difference in these little hairpins? All right, as we move along, you'll see a contrast. Now this is ventricular fibrillation. There's no little P waves that you can see, and there's no tight little hairpins going up, right? In fact, there's no order in this at all, correct? There's nothing here that you can say, oh, that's a complex, that's a complex. It just looks like it's all jumbled up. This is ventricular fibrillation. This is what the heart's doing in cardiac arrest. You just got a bunch of firing going on there. It can't get organized, so it doesn't produce a pulse. So this is ventricular fibrillation. Now it can be big like this. We call this coarse VFib, but you can also have it where it's very fine, where you don't get these larger ones. It's just really small and jaggedy along there. That's VFib, ventricular fibrillation. This is ventricular tachycardia. You notice I didn't say anything about a sinus rhythm here, right? Because it's not coming from the atria. This is coming from the ventricles. And the way you can tell this is ventricular is these big old wide complexes. You don't see those little hairpin things, right? Those little skinny hairpins mean it's coming from the sinus node. When it's wide like this, it's coming from the ventricles, which is never good. So this is ventricular tachycardia. You can see that they've got a rhythm there, right? It's pretty organized and it's fast. Yeah, pretty much. Well, they actually look worse than this.
We, for one of our labs, we had to sit there and count all those things, like, every week.
Well, that's
I've seen
good.
so many of those.
Is that, do you recognize that? The A means without. We know what systole is, right? Remember diastolic and systolic? What's the systolic? That represents the contraction of the ventricles, right? So asystole or asystolic means there's no contraction of the ventricles. And this is what you get, flat line, asystole. We do not shock that. You cannot make that better. What'd you say?
So diastolic is like the pressure at the root.
It's releasing, Yep, it's the relaxation phase. Good. Okay, AED safety. Do not defibrillate a wet person. Do not defibrillate if the patient is touching anything metal, like the little side arms on the stretcher. You know, they're resting their arms there. Don't defibrillate them until you move their arms. They're laying on something metal.
You take off all their
No, they can just fry it. That's okay. No, I'm not. I wouldn't waste any time taking off their jewelry. Remove any nitroglycerin patches. You don't want to put a pad over a nitro patch. A lot of your patients may have nitro patches on, so don't put your pad over there because there's a little backing on there that may actually, interfere with the movement of that electricity through there. So you want to take that off, or else move your pad somewhere else. Make sure you clear everybody. The first time you shock your partner, they're going to be very angry with you. So make sure, what happens here is other people that are assisting you, they're not paying attention to what you're doing. They've got things going. You may have a medic that's intubating. You may have somebody that's getting the long backboard, or somebody doing one thing or another. So there's a lot of activity around your patient. So make sure you look with your eyeballs. Don't just say clear. You need to look all around there. You may get family members that are all anxious about what's going on, and they may crowd in there. They may, be reaching down to grab the patient. So make sure you look before you defibrillate anybody. You can defibrillate a patient if they have an implanted pacemaker. That's fine. The pacemaker not working. So you can defibrillate them. Just don't put it right over the device. Your AED should be checked every day. Check the batteries. Make sure it's functioning. It'll have a test button that you can push, and it'll run an internal test and print a report for you. But if it's not working, you're not going to be shocking anybody. The most common cause of AED malfunction is operator error, in that you have failed to check the batteries. Most commonly, that's the problem. Make sure you got spare batteries. You do not want to have to explain to the family why you didn't shock your patient, especially trying to tell them why you're like on the witness stand. Yeah, we forgot to check the batteries. It was her fault. Okay. Anytime you shock a patient, your medical director is going to get that report. He's going to go through it and make sure you did everything right. It's important. Interrupt CPR only when absolutely necessary for a shorter period as... How long should you spend maximum changing compressors, changing people? 5 seconds. That would be the 5 second. You do have to pause CPR to do a rhythm analysis and to shock your patient. Don't interrupt the compressions for longer than 10 seconds for any reason, but to change partners, change positions, it's 5 seconds. 2 inches deep for adults, or 1/3 of their chest for infants and children. Okay. The rate should be at least 100. That's the rate for everybody except a newborn. What's the rate for a newborn? Oh, she asked me a question I didn't know. No. You just killed them. 120 is the minimum for newborn.
Do they have a song for that one?
Do what?
Do they have a song for that one?
Just sing faster. Have any of you guys ever done CPR? You done CPR? It will wear you slap out, won't it? It will wear you out. So be prepared to change compressors because you'll get tired very quickly. Now, if you have a ROSCO, which stands for return of spontaneous circulation, some things you're going to be looking for is if the patient starts to move. And this is not every time you press the chest down, they go like this. That's not it. If they actually appear like they are recovering, first thing you want to do is check for pulse. But if you've had a ROSCO, you want to get a baseline set of vital signs so you have a starting point. Put them on oxygen. Now, most of the time with a ROSCO, they're not going to start breathing spontaneously at 15 times a minute. Even once they get a pulse return, it's probably going to be either slow or fast or irregular. The blood pressure is not going to be there right away, and their respirations will probably be depressed. So you may bag them even after they've gotten a pulse. You may bag them for some length of time. Don't take the pads off, because once you've defibrillated a patient, there's a good chance they're going to go back into cardiac arrest and we have to use them again. Post-resuscitation care, once they have a pulse back, manage the airway, don't overventilate them, keep the pads on. You want to reassess them frequently, at least every 5 minutes. More than likely, they're going to remain unconscious. So you're really going to need to be checking that pulse frequently. If they're unconscious, you probably need to check it every 30 seconds to a minute because they could lose their pulse and you wouldn't know it, right? There's nothing telling you that it has a pulse. The only way you ever know if a patient has a pulse is you're feeling it. If you put a pulse oximeter on here, is it going to tell you anything? It may not read. They may be vasoconstricted. You know, it may not read for you. So the only way you're going to know if they have a pulse is by feeling it yourself. Consider hypothermia protocols. The patient goes back into cardiac arrest, you just basically start over. If you're traveling and they going back in cardiac arrest, you got to stop and work through your code. You'll analyze the rhythm, shock if they're indicated. You don't want to be moving and be trying to analyze the heart rhythm. You want to do that while you're stopped. Okay, mechanical devices. Boy, I forgot to erase that. The thumper, the auto pulse, read about those. There's a lot of good information about those. It's something that if you have any interest, you may do some research on the internet. It's kind of interesting. They can be quite effective. Y'all going to do this review on your own pretty much? We will be doing cardiac patients as part of our medical assessments in labs, so be prepared for those. You've got to be able to recognize all the signs and symptoms. Now please read through this stuff. I'm kind of going through here because we got a whole other chapter to go through. The most important element of cardiac arrest care is the administration of high quality chest compressions. CPR is very important. I'm not doing it. Huh? Hey, you have a 78-year-old male who's been complaining of severe shortness of breath for 20 minutes. When you arrive, you find the patient unconscious and not moving. What are your immediate priorities? Yeah, you have to check what? ABCs. If he doesn't have those, you're going to start CPR, text the AED. Now, if you get there and he's unconscious and he's in cardiac arrest, are you going to do CPR or not? What's it going to depend on?
Someone else already started.
Yep, somebody doing CPR when you get there. In this case, there's no indication, so I'm going to start CPR.
Oh, I need to
Show it to somebody you know. I had that as my screensaver forever.
It makes me laugh when people talk about, I can't lose weight. It's like, well, have you dieted? No. Do you work out? No.
Some people still do that.
Can I just take some type of pill to make me skinny?